Do you pee a little when you cough or sneeze? Or maybe you've had period pain and pain with intercourse for so long that it's become a normal part of your life? I'm naturopathic Dr. Ann Hussain, and this is Phase to Phase. Today, we are talking about the pelvic floor, an area of the body that has historically been missed or overlooked, except for maybe in postpartum settings. And I do think now it's getting a little bit of the spotlight because perimenopause is in the spotlight. But still, it's an area we don't really talk enough about and women don't get enough care for, even though it can have such a big impact on our lives, from digestion and urination to periods and intimacy and even chronic pain. And today, to help us understand what the pelvic floor does, what it is, and how it can show up and what to do about it, we have someone very well versed in the pelvic floor itself. Today, we have Sheela Zelmer, a pelvic health physiotherapist and intimacy coach in Newmarket and Aurora, Ontario, Canada. Sheila's mission is to help women know and love their bodies so that they can live their life to the fullest. We've known each other professionally for many years, and I feel like you've known me since I was a baby ND turning into an adolescent ND, and you were kind and gracious enough to meet with me. I can't remember if it was a coffee or a smoothie or a juice.
Yeah, it probably was one of those. Yeah, for sure. I do remember we had just moved from Ottawa here, so it was great to network and meet sort of like-minded people, which was fantastic.
Yeah, and thank you so much for being here. I'm really looking forward to this conversation, and I know it's going to be a very important and illuminating conversation for a lot of people, especially if they're not familiar with the pelvic floor. We're going to start with pelvic floor 101. Can you tell us what the pelvic floor is and what it does?
Yeah, okay. First of all, I think it's important that everybody has a pelvic floor. We tend to think that women are the only ones with pelvic floors, but everybody has one. Kids, men, women, everybody. So the pelvic floor is a group of muscles that runs from our pubic bone in the front and it goes all the way to the tailbone in the back. And its job is so multifold. So it does provide bladder and bowel control, like you mentioned earlier, but it also has a supportive function. So it provides lift to our organs. It has a sexual function. So it has to be able to, hold a contraction, maintain arousal, be able to widen for penetration and things like that. It also works with our core as a system to provide stability, and it acts like a sump pump to help with circulation. So it's this hidden area that has so many functions.
And when the pelvic floor isn't working properly or the muscles aren't coordinated, what can that look like?
So, if we think about the different functions as being its job, then when it doesn't do those jobs, we call that dysfunction. So it can look on a very simplistic level, and I think many people will think about this as bladder leaking. So maybe when I cough or sneeze, I leak a little bit of pee. Or maybe if I've been holding my bladder for a really long time, maybe I was busy in a meeting or something like that, then all of a sudden I have this very strong urge to get to the toilet. And by the time I'm getting my pants down, a little bit of pee is coming out. It can look like that. But it can also look like I have no ability to control. I roll over in bed and I leak and things like that. But it can be our bowels, it can be gas, or it can be urine, any of those. But that's just one dysfunction. We can have struggles with, say, intimacy. Maybe there's a struggle with achieving penetration, if that's your goal. Maybe there's a lot of pain or tightness or difficulty allowing your body to relax. There can be difficulty with arousal. Maybe things don't feel like they used to. You don't feel much, or it takes a really long time to have an orgasm. So it can look like that. We can also have issues with things like pelvic congestion. So that is sort of an achiness or a heaviness that might be associated with our periods. It can be associated with sexual activity. Any kind of really intense sort of high energy activity in the pelvis can cause that kind of congestion if that is dysfunctional. But we can also have things like pelvic organ prolapse. That's when our bladder, uterus, or rectum starts to drop. And so we feel this heaviness. It might feel like there's a tampon that's sort of half sitting in the vagina. Or maybe when you wash or wipe, you feel a little ball or a bulge that's there. It can be difficult to say have a bowel movement. You'll feel like I know I've got to poop, but when I'm sitting on the toilet, it's not coming out. Like there's something, or I went poop and it doesn't feel like it's all out. So it can look like a lot of different things, but that's just a smattering of some of the dysfunctions that we see when the pelvic floor is not doing its job properly.
And at the top of the show, I said that pelvic floor, not a lot of people know about it, and
Hmm.
it hasn't really been something that's been discussed in the wider media and the world and health in general. Would you agree with that statement? And because you've been practicing for so long, how have you seen that shift over time?
Yeah, I would definitely say that there is still a lot of taboo around it. And even within pelvic health, I think it's wonderful. Like you said, there's much more awareness, whether it's social media, and, things like the M factor talking about like perimenopause and menopause. So there's a lot more in the media talking about these aspects. And of course, I think the generation that's going through, say, perimenopause, that Gen X, they are very vocal about things. So yes, there's certainly more conversations, but I think so much of it is it's shame based. There's a big cultural aspect to this. So my background, my family is from India, and I certainly grew up in a very modest household where there was not a lot of talk about how our bodies were dysfunctional. There was, very superficial talk about how periods are supposed to function. Here's where the pads are. And that's about it, but not really a lot about how to care for ourselves and what to look for. I have a vivid memory of my mother and some of my aunties in the kitchen. They were chit-chatting with one another and laughing. And one of them said, "Don't make me laugh too hard because I'm going to pee." And I remember being mortified. I was a teenager thinking, what are you talking about? And they said to me, don't worry, that's going to happen to you. So I think there's also this normalization across, whether it's amongst families or across cultures or just in society as a whole. There's far more products, for example, for bladder control leakage, whether that is different pads and different devices. So it almost sets up this normalization that, yeah, this happens to everybody. So don't worry about it. Just use this instead of saying, this is a sign that something is not working properly. So let's listen to your body and see if we can address that. But I think there is a lot of shame and hiddenness about this. And there can be cultural, religious. My family's also Christian. So again, we didn't really talk a lot about this sort of stuff. There's a lot of modesty there. And that can be a big variable. It's not unusual to have women of, all ages come into my office and have a hard time even naming their body parts. They're not even comfortable using the proper anatomical terms. They say down there as opposed to vagina, you know?
Yeah, I completely like as you were speaking, I was reflecting on my own experience, and similarly, so I come from a Muslim background and growing up in Pakistan, and told this story on the podcast before. My period took me by surprise the first time I ever had it, and the conversation around our genitals was really nothing.
Yeah.
I would really say it was nothing.
Yes.
Right. And even when I used to go to the family doctor, the conversation was don't let them give you a pap because there's this stigma and taboo about even like, the quote unquote virginity testing,
Yes.
right? Like, or the hymen breaking and things like that. And that stays with you. It's really difficult as you get older to not have a little bit of disconnect from that part of yourself. And language wise, same thing when I see patients in practice we really have to clarify if we're talking about the vulva, if we're talking actually about the vaginal tract, if we're talking about a different area, right? Like, so the diagrams are really helpful. And interestingly enough, I don't know if you find this, but the diagrams, their uptake is actually pretty good. I find that the language piece is the harder, at least in my practice.
Yeah, I think some of the words like vulva, vagina, but even like scrotum or testicles, like those words don't sound like nice words. So I don't know if that's what it is, but I think people want to make light of it. So, to call it different terms that are much more light. But it's a really interesting thing. There is research that says regarding women that when women can accurately describe what they're experiencing and where they get access to better care, right? So I think it's really important that we help young women to go into this phase of their life with that knowledge and that comfort level.
100% I would agree, especially in your healthcare settings, because then with your providers, we're using the same language and we have
Hmm.
clarity around exactly what part of the body that we're talking about. Now, since we're talking about stigma and taboo, and sometimes people have a lot of apprehension about this part of the body, can you take us through what an assessment looks like, a pelvic assessment looks like, and how you overcome or how you discuss the assessment and what you're doing with your clients so that they're at ease? Because there can be, like you said, some religious cultural things, but there can also be a history of trauma. There can be
Mhm.
significant pain or friable tissue, so tissue that isn't necessarily like strong because of hormonal changes or because of something else that's happened.
Yeah, I think that's really, really important to acknowledge that we want to meet clients where they're at. And it is not unusual to have had clients that are experiencing symptoms that have medical trauma, even, so medical trauma, whether they've had procedures that have been performed without their full consent, without understanding what that's going to be like, maybe procedures that were painful and they were dismissed, where they have not felt that they were heard or acknowledged. And so I really want to make sure that when clients come in, that they feel safe, that they feel that they are truly understanding how things are going to unfold and that they're ultimately in charge. And so, it's almost like a menu rather than saying that this is what you must do. We really try to lay it all out. So a big portion of the initial assessment when someone comes to see a pelvic physiotherapist is the whole history taking. It's the conversation, understanding what they've been experiencing, how long that's been happening, and how it's really impacting their life. And that really is important because sometimes people have gone in for, say, a pap test. And, when the doctor is performing the pap test, they say, oh, you've got a prolapse. And they throw this word around that sends them to Dr. Google. And now they go into a tailspin. So, really, to explain what they're experiencing and how that has shown up, what they have done in the past prior to coming in to see me. So I think that's really important. And then once we have a bit of an idea of sort of how this has sort of presented itself and what their goals are, because for some people, their goal is they want to be able to continue to be active. They want to be able to hike, pick up their grandkids. They want to be able to travel. They want to be able to have sex and enjoy it and not be self-conscious about how their body looks or performs. So really to understand those nuances. And then there's a physical exam. So the physical exam will often, I would say most of the time, we would recommend an internal vaginal or rectal examination, possibly both. And so that examination is not like a pap test. So clients they will be lying down on their back, but there's no stirrups for your feet. There's none of this scoot your bum down, scoot your bum down. There's nothing like that. You're completely draped. So you've got a nice big sheet that covers from your waist down to your feet. Your knees are bent. And I sit at the side. We can call it European style if you want. So it's like side saddle. I sit at the side, and then the examination involves inserting my hand, one, possibly two fingers inside the vaginal canal, and we're doing it in a very gentle way. None of this examination should elicit a protective response. Like the last thing I want you to do is to be tensing up. I've had a pap test where the doctor says, oh, just relax. If I am not able to relax, that is not the patient's problem. That is the practitioner's problem that is not making a relaxing setting. So I really want to make sure that my clients are comfortable enough to have this examination. And then during that examination, because these muscles run along the vagina and the rectal area, I'm evaluating how well do you contract? Can you hold that contraction? What happens when you try to exert some pressure? Cough, maybe do a crunch, engage your core. What happens to the way that you are able to use these muscles? And so based on that, we give exercises, right? And so that might be Kegel exercises that people are familiar with that term. We call them pelvic floor muscle training rather than naming them after the doctor that invented them. So, and that can look like different things. It can look like squeezing the muscles. It can look like core strengthening. It can look like getting into the gym and doing things like squats and lunges and breathing correctly, engaging the diaphragm, the breath, all of those sorts of things at the same time. So it can look like many different things, but it often will involve that internal exam. But that piece of the internal exam should not be something that is painful, should not be something that is fearful. And there are situations where clients don't feel comfortable with that. It's maybe our first time together. They don't know me. They're not quite sure. So we don't have to do that. We can do other things. We can do core exercises. We can look at posture and alignment, maybe things like, again, going back to the squats and deadlifts. We don't have to begin with an internal exam until the person is comfortable for that.
Thanks for that thorough explanation because I send a lot of patients to pelvic floor physios because of the patient population I work with. Oftentimes they're perimenopausal or postmenopausal. My fertility patients are postpartum patients, and endometriosis or period pain patients, right? Like
Hmm.
that's my primary patient population. And I often will send to pelvic floor physiotherapy. And it is transformative in so many ways. And at the very least, even if there's no pelvic floor dysfunction, it really does connect the person to that part of themselves. And they always leave with something like learning about their pelvic floor, learning how to breathe correctly, learning about posture, learning about their musculature. You mentioned Kegels and the pelvic floor strengthening exercises. Now, what else could that look like? You alluded to some of this, but can you lay out, like, if someone does have, let's say, an uncoordinated muscle response, or there's areas of tension where maybe we're not trying to contract that muscle, we're trying to relax those muscles. What can some of the pelvic floor care look like in terms of exercises?
Yeah. So I think once we've sort of figured out how is this muscle functioning, so if we take it outside of the pelvis and say we're talking about someone's lower back, we know that not everybody needs the same kind of exercises for their lower back. There isn't one recipe or formula for everybody. And the same goes for the pelvic floor. So you'd mentioned sometimes people have too much tension, and that is really common. So if I have a lot of, let's use my neck and shoulders, if I have a lot of tension in my shoulders are often up by my ears, the plan of care is not necessarily going to be, now let's go to the gym and start doing shrugs. It might be, let's work on posture. Let's work on relaxation. Let's work on your awareness of where are your shoulders even sitting in space. And so this is a big piece of what we do because I think by far the majority of clients that we see have too much tension. We tend to think if we're having dysfunction with the pelvic floor, I must be weak, in quotes, right? But what does that mean? Weakness can exist on two ends of a spectrum. It can be weak because things are very loose or low tone. But we can also be weak when things are too high tone and a muscle's not able to generate the contraction properly. So it is figuring out where they are on that spectrum and starting there. So we had talked about breath. Breathing is so integral because when we think about our core, we tend to think about our abs, maybe our back, but our core is actually a cylinder with our abs in the front, our back. We have our diaphragm, the respiratory diaphragm that sits on the top, and then the pelvic floor that sits on the bottom. And this is a four-piece system that works as a unit. So it's not unusual to have clients that come in, say in their whole life, they always held their tummy in. Maybe they've done that for aesthetic reasons. They're a little self-conscious about how their abs look, and so they want to hold their stomach in all the time. Or perhaps they've had a history of lower back pain, and that's how they sort of provide some support by tensing their abs up. But when we do that, it is really challenging to breathe normally. We cannot take a nice deep breath if we're holding our abs in. And if we are not able to breathe, not able to relax the abdomen, the pelvic floor has to really fight against that pressure and it stays on all the time. So it's really unpacking all those pieces and figuring out what is the weak link in the chain and addressing that. And it can look like so many things, but often breathing is a part of it. Relaxation is a big part of it before we can start building and building strength. Yeah.
As you were saying that, I'm like, oh, let me just unclench everything and breathe more deeply. In a similar vein, I want to actually talk about bladder or urination frequency. So when we're kids, our parents always, before going on a long drive or before leaving the house, they were like, empty your bladder. So a lot of women and a lot of people, as we get older, we sort of adopt that habit of, oh, I might need to pee later, so let me pee now. Can you take us through if that's a good practice or if someone has urinary frequency or urgency? Is that helpful? Is it better for us to sort of try to expand our bladder a little bit because the bladder ultimately is a muscle? How do you look at the bladder function in that way?
Yeah. So when you're looking at the bladder function, we kind of have to think about what's going in and what's coming out. So assuming that someone doesn't have any kind of bladder issue, there's no infection or no dysfunction with the bladder as an organ itself, we want to be voiding about every 2 to 3 hours, right? Sometimes it might be a little bit less, might be a little bit more, and that depends on how much fluid we're consuming. That varies as well. But if we're drinking, I don't know, 1.5 to 2 liters of fluid, again, there's not really specific guidelines. It depends on, are you a mouth breather? Are you physically active, etc. But if we say approximately 1.5 to 2 liters of water or fluids per day, that should equal going to urinate every 2 to 3 hours. And so if you are going more frequently than that, so oftentimes people will then cut back their fluid, right, to manage that. They'll say, well, I just shouldn't drink that much, and therefore I won't go pee. But if you are finding that despite all of that, you are voiding every hour, hour and a half, or you have a lot of frequency, or like you described, you find that you're using what we call just in case voiding to manage, okay, well, I know that I might have leakage, so I am going to go pee now so that I don't have leakage later. Or I know I am going to be going into a meeting and I'm not going to be able to leave partway through, so I'm going to go pee just in case. So when we do that, unfortunately, we interrupt some of that reflexive filling and emptying that the bladder and the pelvic floor muscles and the sphincters are supposed to do. The bladder is a muscle, it's meant to hold. And it is when it is sufficiently full, which can be up to 500 milliliters, right? Like that's a really good volume of urine in the bladder, that is what tells us it's time to seek a toilet and void. But if we start interrupting that and we're going pee just in case, we get our bladder to hold less and less and less. So it gets used to holding a smaller volume. And it may seem like it's helpful in the beginning, but you're shortchanging yourself long term, right? Because you are then training the bladder to hold less volume. So therefore, you're going to have more frequency.
Thank you, because I have a lot of teachers who come with this complaint, right? And again, like it's been something that they've been doing their whole life, similar to what we said earlier. It's been normalized.
For sure. And teachers and nurses, they're a population that really struggles in this area because they don't have the ability to void when they want to, right? And so they're going to the bathroom at set times. They're maybe not trying to consume fluids during their working hours, and then they're loading up in the evening. Therefore, they're peeing all night. So it really sets up this dysfunction there. It can be really challenging in that population.
And when you're doing an examination, what else are you looking for, especially in the vaginal tract? I want to focus a little bit on there because what I also really love about sending patients to a pelvic floor physiotherapist or a pelvic physiotherapist is that I get a second set of eyes and a second opinion on the vaginal tract itself, especially if someone is having vaginal irritation or vulvar irritation, itching, low libido, low lubrication. What are you looking for?
Yeah, that's a really great question because many times clients have come to see me and they have not even looked with a mirror themselves. So they're not even sure what they're looking at or what their version of normal is. And so one of the things that we want to take a look at is we want to just sort of see when we have the client open their legs and we're looking at their vulva, what do we see? Do the tissues look healthy? So just like we look at our face, the vulva is not necessarily symmetrical. We have asymmetry in our face. Every face is unique. So we don't look like the pictures that you might see on a diagram. We certainly don't look like what the pornography industry says that we should look like. And so we want to take a look at what is happening here. It's very normal for there to be hair. Sometimes that hair becomes sparser as we see hormonal changes. So it's often more of a thinning of the hair. We could get gray as we look at the labia. And so looking at what that tissue looks like, but there should be like a pinky rosiness to the tissues. When we see tissues that are estrogen deprived, so a hormonal deprivation, maybe this is after having a baby, maybe with breastfeeding, could be around perimenopause to postmenopausal, we can see much more pale tissues. They look more blanched, if you will. So we're taking a look to see, is there a sign of hormonal loss? Just like we can lose fullness in our face as we get older, we can lose fullness in the labia. So when we're younger, the labias tend to be a little bit more tightly pulled into the body. But as we age, they tend to be a little bit, maybe a little bit looser, maybe a little bit thinner. So we're looking at all of those aspects just externally, but also for any signs of irritation. So there can be a lot of dermatological conditions that clients might experience that might cause itching or burning. So we're looking for signs of redness, signs of, like I said, the estrogen loss, any signs of maybe they've scratched, because again, if we've got nails and you scratch because it's itchy, that can create an irritation there as well. And that's just looking externally. When we do the internal exam, I really am concerned with how dry the tissue is. So the examination is done with lubricant, but sometimes even with lubricant, we can feel a bit of dryness. So we think of the vaginal canal like a pleated skirt that a woman might wear. So if we can picture, a very densely pleated skirt that a woman is wearing, and when she's standing up, it kind of is triangular shaped and it's got all these ridges. That is quite normal. We're supposed to have all of those rugae, all of those tissue folds within the vagina. That allows the vagina to expand and stretch for penetration, examinations, etc. When we have changes, it almost becomes smoother. So instead of it looking like a pleated skirt, it looks more like a pencil skirt, right? And so if we start to notice some of these changes, this is something that I want to alert women to. Perhaps their primary care practitioner has not done an examination, but they're experienced discomfort, say with sexual penetration. Maybe they're feeling a lot of urgency of their bladder. They always feel like they have to pee. And these can all be signs that there's something from a tissue health perspective that needs to be addressed. But the other thing that we look at when we look at a vaginal examination, and my finger is inserted, I'm looking for what do the vaginal walls rest at the resting position. Is there a descent of the vaginal walls, which could be indicative of something like prolapse? So we're wanting to see, is there a nice canal for the vagina, or is there something that's sort of in the way that can be moved out of the way gently? So again, that is a lot of what we're taking a look at, but we're going by touch. We're not inserting a speculum and taking a look inside. We're going by feel to see what women are experiencing and if that correlates with what I'm finding on examination.
You started this answer with how a lot of us don't know what our external genitalia look like. Do you typically encourage patients or clients to look at their external genitalia using a mirror? And what kind of feedback, I'm curious, do you get from them?
Yeah, so this again, I think goes back to, I'm going to almost say a generational thing. So I will say that older generations are more reluctant. We've got all kinds of negative words for what our vulva looks like, or, oh, it's gross, it's ugly. Ugh, I don't even know. I'm freaked out when I look at it. These are sort of the things that women say to me. So I do encourage women to look at their vulva. I do encourage women to be comfortable with it from a health perspective, but also there's a real associations with sexual pleasure and being able to identify from a proprioceptive perspective what our vulva, vagina, the clitoris, all of it, what it is looking like, and can we connect that to the sensations we're experiencing. So particularly my clients that are having a difficult time with libido or arousal, this is something that we spend a lot of time taking a look at so they can really almost form a body scan of what their vulva and vagina is like.
Thanks for that. I always feel quite privileged. So I used to be a birth doula. So I have been in so many birthing rooms, even, right? Like in hospital rooms. Not a lot of people get that experience and chance. And obviously, you've seen many.
Yeah, it was very therapeutic of me to take the courses for pelvic health because when we take these courses, I don't know about in the ND program, but like in physio school, when we are learning a technique, say for your shoulder, we're practicing on one another. So, shirt comes off, you're in your bra, and you're amongst all your classmates. And it's the same with pelvic health. We are learning on one another. And so I had never seen another woman's vulva. I'm in a heterosexual relationship. I'd never seen another woman's vulva before these courses. And so to see, oh, these are real women, and look, there's 5 of us and we all look different, it was so therapeutic and healing for me to normalize my body and to feel much more comfortable with that. Another interesting thing, so we will often do physical examinations on clients when they're menstruating, and that can also be another taboo. Women feel apologetic that they're bleeding when they come to see me, that they're saying, I'm so sorry, I'm on my period. Like, why is that an apology? You're doing something your body is supposed to do. I'm happy to do your examination. It's not messy at all. Don't worry. We both menstruate. It's good. So to normalize having a period.
And I like how you mentioned how women are so apologetic because they're
Hmm.
apologetic about not having their nails done or not shaving their legs or having
Yes.
hair or sweating or having very normal bodily functions.
Yeah.
Okay, as we approach the end of our conversation, I'm hoping that you can summarize perhaps what are some of the things that should be alerting people to seek out care from a pelvic physiotherapist or getting some pelvic floor assessments done. Like, what are some of the things? I know we've talked about a few of them, but if you can summarize for us, that would be really helpful.
Yeah, for sure. I'd say the biggest thing is to not dismiss symptoms. I think especially when we are experiencing struggles, say on a very small basis of leakage, maybe every now and then, like I just had a cold, I'm coughing, and I might feel like I'm going to pee, or maybe there's a little drop of urine, that we dismiss that. No amount of leakage is normal. So whether that is bladder, bowel, or gas, that is not considered normal. The other thing that is not normal is pain. There should not be pain when you have your periods. There should not be pain when you have sexual penetration. There should not be pain when you have a bowel movement. There should not be pain if your bladder is very full. All of these things are signs that your body is telling you something. And, we want to really intervene early because some of these dysfunctions can become more problematic over time and when we superimpose hormonal changes. So if you have a woman that after having her children starts to notice leakage and she leaves that for decades until she is in postmenopause, now you not only have the tissue related changes from a muscle perspective, but we also have tissue related changes related to hormones. And that becomes much more complex to manage later.
Yep, chronic pelvic pain is another one I want to mention.
Hmm.
And if you have a diagnosis of endometriosis, that's also when I really want patients to go see a pelvic physiotherapist. And what is the process typically for someone working with a physiotherapist? Do they need a referral? Do they need to just reach out? How does that work?
Yeah, so you can just reach out to the physiotherapist and book an appointment. You don't need a referral. Now, physiotherapists are regulated health professionals, and so many people have health benefits. And if you do, some benefit plans do require a doctor's referral in order to be covered. So you need to check your own benefits, but the physio themselves don't require a referral for you to see them.
Now, final two questions for you, Sheila. Number one, is there anything, any words of wisdom, anything that you didn't share earlier on that you would like to share with people who are maybe experiencing any of the symptoms that we've talked about today?
So I would say for sure, reach out to find a practitioner around you that can help you. That's number one. But also share what you're experiencing and what you are doing about it with your friends, with your sisters, with your girlfriends, because we talked about how there's so much stigma. And when people are experiencing issues, let's say around like sexual penetration, there's pain with sex, or they have no libido, it can be very isolating because you feel like you're the only one. Everybody's joking about their sex lives or ha ha ha, but nobody is talking about, hey, I don't feel like I used to. Is this normal? Maybe you don't have the type of relationship that you could have this conversation with your family doctor. But if we start having the conversations amongst our friends, amongst our sisters and aunts or whatever, we then start to normalize things so that we can allow women to get better care. So I would say that is the biggest thing. Don't keep the stuff to yourself.
Number two, we're big on growth here at Phase to Phase, especially changing our minds or adding nuance when we make, especially when we make progress in health and medicine. Is there a concept, belief, or strategy within your professional expertise that you have changed your mind on, or something that has evolved or shifted for you over time?
Yeah, for sure. I think, you know, pelvic health, women's health has really grown so much. And, I've been a physiotherapist for a really long time now, and things are just so different than when I first started practicing. So I would say the biggest thing is like our bodies are not a problem to be fixed. And I think I really used to segment the body into weakness of this muscle, tightness of this muscle, and these were problems that needed to be addressed, rather than looking holistically as how is this impacting this person on a day-to-day basis. Because there are some things, so like if we use the example of prolapse, I would previously have said, well, this is weakness that needs to be strengthened. This is a bulge that needs to be lifted. And we would be so hyper-focused on that that we would lose sight that this is part of a woman who wants to be able to lift her grandkids. She wants to be able to work out so that she can manage bone density issues, etc. And really zooming out to sort of say our bodies are so resilient. If we can empower women to feel confident, to be their best selves, we may not fix all of the dysfunctions that are there, but we can look functionally at how a woman is functioning as a whole and really make a huge difference. So I think that's the biggest thing. So less problem focused and more, I guess, lifestyle focused. Yeah.
Treat the person, right?
Yeah.
hmm Okay, and number three, tell the people how they can find you, connect with you, and work with you.
Amazing. So you can find me online. So SheelaZelmer.com. That's my website. There's a little bit of information about me. There are links to book. I see patients primarily in person. Virtual is an option for follow-up appointments, but I would definitely recommend for the physical exam, an in-person examination is the most valuable. And so that's for Ontario residents in Newmarket. You can come and see me at the clinic there. I would love to connect with anyone.
Sheila, thank you so much for being here. Thank you for imparting all your wisdom.
Thank you so much. This was a lot of fun. I really appreciate it.
You can find Sheila's links in the show notes. Make sure to subscribe and follow wherever you get your podcasts or at face2face.ca.